Khorana score is a risk stratification tool that has been around for a while. I think it was first developed in 2008, and it takes into account 5 factors that are supposed to be predictive of a VTE or venous thromboembolism in a cancer population. Those 5 factors are the primary tumor site, platelet count, hemoglobin level, white blood cell count, and the patient's BMI. And using a score based off of those 5 factors, you should be able to get a risk stratification for the likelihood of developing a VTE. Now, this has been a validated tool in multiple different types of tumors and cancers, specifically when looking at patients undergoing chemotherapy. However, it has not specifically been studied in uterine cancer, which is what we attempted to do with this project that I'm presenting at ASCO. And it's just starting to get looked at in ovarian cancer, so the two most prevalent gynecologic cancers. Currently, the only usage of this in practice is with the recent clinical practice guidelines from ASCO stating that anyone with a Khorana score of 2 or greater should be offered thromboprophylaxis during chemotherapy. However, this is not yet widely used in the gyno community.
Based on the evidence that we do have, patients with active cancer and a score of greater than or equal to 2 will likely benefit from thromboprophylaxis during treatment. The initial study that was used to develop the Khorana score included a mixed population of patients with different cancers, including breast, colorectal, lung, gastric, and pancreatic cancers, and lymphoma. Only about 10% of the patients included had gynecologic cancer. Since gynecologic cancer is a big category, including women who are undergoing different treatments for uterine, ovarian, cervical, vaginal, vulvar, and gestational trophoblastic disease, all of these cancers behave differently and are treated differently. So therefore, it remains unclear if we can really extrapolate the Khorana model to all of these different disease sites.
Based on the patient population that we looked at for this study, we looked at a patient population at Ohio State for the past 4 years, and all patients that underwent chemotherapy for uterine cancer. We looked at a total of 265 patients and calculated the Khorana score for each of them and saw whether or not that was predictive of them getting a VTE. And for this study, we looked at both a score of 2 or greater and a score of 3 or greater. And unfortunately, neither of those scores were able to adequately predict those at highest risk for VTE. Neither one was statistically significant. And when you look at the score of 2 or greater, which is what the ASCO clinical practice guidelines suggested, it did not correlate well at all with the risk of getting a VTE. When you raise that to a score of 3 or greater, it correlated with VTE, but it was not statistically significant. Now, this doesn't mean it's an unuseful tool, but I think at this point, it needs to be used with caution because it is not able to adequately stratify patients into a high-risk category.
So our findings indicate that a Khorana score of greater than or equal to 2 was not associated with an increased risk of developing VTE relative to those with scores of 2 or less, and therefore it might not be a reliable predictor of VTE in patients with ovarian cancer. Other studies have shown that the Khorana score may not be predictive of VTE in patients undergoing treatment for other cancers, such as lung, pancreatic, and high-risk uterine cancer. Our results show that maybe not all cancers behave in the same way in terms of VTE risk, and other models may be needed to help risk stratify specific populations rather than all comers.
In in addition to looking at the Khorana score, we also looked at common factors that we would look at for being associated with VTE, including the patient's age, their BMI, their race or ethnicity, the histology of their tumor, the grade or stage of their tumor, whether or not they received radiation treatment, and whether or not they received adjuvant or neoadjuvant chemotherapy. And unfortunately, none of these correlated well with the patient's risk of VTE. So it's similar to when we looked at the Khorana score, we are not yet able to find a model, either univariate or multivariate analysis, that is able to predict which patients are at higher risk or highest risk for developing a VTE during chemotherapy.
In our analysis, after adjusting for other covariates, the only covariates that were significantly associated with VTE were obesity, stage 3 or 4 disease, and epithelial histology. Burden of disease and histologic aggressiveness are variables that aren't factored into the Khorana score, and these variables might help better identify patients at a higher risk of VTE.